Welcome back to another Diabetes Canada healthcare provider webinar. Today is the first of a two-part series on the cardiovascular and metabolic impact of insomnia, how sleep can be contributing to the problem. My name is Grace Slater. I'm the manager of healthcare provider education, engagement, and professional membership, and very excited to be introducing Dr. James Kim, who's going to speak on today's topic. Dr. James Kim is a clinical assistant professor in the Department of Family Medicine at the University of Calgary and has a special interest in diabetes, metabolic dysfunction-associated steatotic liver disease, or MASLD, and chronic migraine. Since completing his master's program in the healthcare professional education, Dr. Kim's interest lies in effective healthcare professional education delivery methods and has been invited as a guest lecturer at a number of universities and conferences on this topic. He's also the lead editor for the primary care section of the Canadian Journal of Diabetes and co-editor for the Canadian Primary Care Today journal. Within Diabetes Canada, his role includes steering committee member of the Clinical Practice Guidelines, current co-chair of the Primary Care Special Interest Group, dissemination and implementation committee member, and author of the guidelines, lead author of the MASLD guidelines. Within Migraine Canada, Dr. Kim is a scientific committee member, and he is a committee member of the International Medical Education Organization, and most recently he was invited to join the Global NASH Council as one of the first Canadian members and to collaborate with the leading international experts on MASLD. He is currently leading a major project in Calgary to reduce wait times across the specialists. So today we're going to be focusing on, in this first part video, the link between insomnia and the metabolic risks. So without further ado, I'll pass it over to you, Dr. Kim.
Thank you so much, Grace, for the kind introduction. So thank you very much for all of you for joining this session on the cardiovascular and metabolic impact of insomnia. So as a family doctor, it's a bit embarrassing to say that I used to hate seeing people with insomnia because I just really struggled to relate the fact that the insomnia could be actually that much of a big problem because I sleep like a baby at any given time and at any given moment. But it really became a problem for me when I realized that insomnia actually does occur as a cardiovascular risk factor, and it does impact the cardiovascular and metabolic status of the patient in a very negative way. So that changed the way I started looking at insomnia, and I hope that in next two sessions of this micro-learning sessions, that you will have the same eureka moment that I had. So this is my disclosure. I am not receiving any fund for this particular presentations. So two learning objectives that discuss the link between insomnia and cardiometabolic risks. And second is to apply simple non-pharmacological interventions in our clinic. So first of all, let's meet our patient, Daryl. Daryl is a very classic patient that you may have seen on a daily basis. 58-year-old gentleman known with depression, type 2 diabetes, hypertension, and dyslipidemia on a very classic medications that I think that our patients are taking, such as metformin 1 gram BID, dapagliflozin 10 milligrams once a day, semaglutide 1 milligrams weekly, atorvastatin 20 milligrams, perindopril 8 milligrams, and mirtazapine 30 milligrams at night. As you can see in his labs, his A1C is elevated at 8.2% with a fasting blood glucose at 9.2. His BMI is elevated at 34, but his blood pressure and cholesterol are well controlled. His renal function, well, it looks okay. You could argue that the eGFR could be a bit too low for his age, but for the sake of this discussion, let's just assume that his renal function is fine. So Daryl tells you that he's been prescribed a mirtazapine by his previous family doctor to help with his depression and sleep. And why not? To use one medication to deal with both sounds like a pretty good idea. His sleep, unfortunately, has been getting worse for the last few months, and he often has a difficulty to staying asleep at night and tends to consume snack when he wakes up at night, and that is not a surprise. By the way, there is a plausible biochemical things of happening in your brain, especially when you're tired at night and choosing the wrong food. He wants to know if he can use cannabis or quetiapine because his sister takes it and it seems to work really well. He also has a moderate obstructive sleep apnea, but he's struggling to use a CPAP machine. He's tried a CBTI for his depression in the past and he was not happy. So if Daryl were to stand or sit in front of you, well, you have a number of options. You could argue that you could increase or may want to increase the mirtazapine dose, which is really not recommended. As a matter of fact, the mirtazapine dose may need to be decreased for a number of reasons, and actually it's more sedating at a lower dose. But there are some other reasons that we may not want to use mirtazapine. I'll show you a bit later. We could intensify his CBTIs. That's a cognitive behavioral therapy. I think we should definitely reevaluate his CPAP treatment. Now, the interesting questions arises about his medications. Can we add quetiapine, cannabis, Z-drugs, so that's a zolpidem or zopiclone, or benzo? The answer is probably not to most of these drugs for various reasons. Like quetiapine can increase the weight. Cannabis, I think you have to be a cannabis specialist to really do that. Zopiclone and zolpidem, so the Z drugs, and well as a benzodiazepine can actually cause quite a bit of a problem in terms of the addictions and the tolerability. They don't actually work really well. The efficacy goes down, tachyphylaxis occurs, and people need more and more and more medications. And on top of that, benzodiazepine is probably not the best idea, especially given that he has an obstructive sleep apnea. Or you could add a new class of drug called orexin receptor antagonist. So there are two available, lemborexant, also known as Dayvigo, and QUVIVIQ, which are that's a trade name, so the generic name is daridorexant. Or you could also consider recommending the over-the-counter sleep aid. So there are a number of things that we could consider for Daryl. So what's really interesting is that if you don't sleep well, you tend to gain weight. And if you sleep too much, then you tend to gain weight. This is a very fascinating population study from US that shows that if you sleep too little, in this case was less than 7 hours, and if you sleep too much, in this case was 8 hours, then you would actually gain weight. So there are a lot of hypotheses as to why you would gain weight if you sleep too much. I've read a number of studies, and there weren't any very strong concrete conclusions as to why that would be the case. And by the way, this similar data is shown in various studies done in various parts of the world, not just from US. So some of the hypotheses as to why you gain weight when you sleep too much is that if, number one, if you sleep too much, so hypersomnia, then there is a very good chance that the person may have an underlying medical or psychiatric conditions that may need to be dealt with. So that's the first thing. And the second thing is that the longer you sleep, well, the less you are likely to be active in the 24 hours within a day. So that's why the calorie output or the energy output will be far less than if you were to sleep less than the hypersomnic patients. So that could be one of the reasons. However, we have a bit more concrete evidence than the pathophysiology or the link between insomnia and obesity. So when we are awake at the middle of the night, let's say 2 a.m., and you're very tired, but you still have some work to do, and you go down to your fridge and you open your fridge and there's a chocolate cake and carrots. Now, I am not a big carrot fan, and I don't know if the carrot at 2 a.m. tasted very good. Well, I don't know if the carrot in general tastes very good, in my opinion. So then people tend to reach out for chocolate cake. As mentioned, there's a very plausible biochemical reasons as to why we actually look out for and approach for the chocolate cake as opposed to carrots in the middle of the night. So we tend to choose the wrong food, especially at night. Physical activity goes down, and there is a neuropeptide called orexin, which has been investigated a lot in the world of obesity. And the higher the orexin level, then you're more likely to crave for food. And orexin is a neuropeptide that keeps you awake. So if you are awake during the days, then your orexin level is higher. And as you go to bed, then your orexin level should be lower. But if you are insomnia patients, then you're likely to have a higher orexin level, and hence that can lead to craving for food. There are other possible mechanisms implicated in this pathway, such as a decrease in leptin and increase in ghrelin, which will decrease the satiety and promote appetite. And there's also more opportunity to eat if you don't sleep well. What is the link between insomnia and type 2 diabetes? Well, if you don't sleep well and you have a poor quality of sleep, anyone can actually have an increased risk of developing type 2 diabetes. It is really fascinating. Just because you don't sleep, you can actually develop type 2 diabetes. In one particular population study actually showed that if you, as a female, don't sleep well, then there is twofold increased risk of developing type 2 diabetes. That's quite a bit. And on top of that, if you do have type 2 diabetes, then you're 4 times likely to have insomnia than the general populations, which is really, really interesting and almost in a way a bit scary, because if you have insomnia, you're likely to have a worsening A1C and worsening fasting plasma glucose, which all leads to increase in cardiovascular disease in people with type 2 diabetes. So then just because you don't sleep, you develop macrovascular complications and also microvascular complications, especially in form of retinopathy. There have been some other population studies that have shown that if you don't sleep well, then your chance of developing chronic kidney disease also goes up. So just because you don't sleep, you can increase your chance of developing diabetes, and you get type 2 diabetes, and then your chance of developing insomnia actually goes a lot higher as well, which all leads to worsening of your glucose control that leads to micro and macrovascular complications just because you don't sleep. Another population study that shows that if you sleep less than 6 hours a day, or if you sleep more than 8 hours a day, then your chance of developing diabetes actually goes up. So therefore, the sweet spot seems to be about 6 to 8 hours, especially from diabetes perspective. 2 years ago, there was a consensus report from ADA and EASD that stated that over 50% of the people living with type 2 diabetes suffer from obstructive sleep apnea, and the severity of obstructive sleep apnea is associated with a poor blood glucose outcome as well. So that is really interesting to think that over 50% of our patients with type 2 diabetes actually have OSA and may not have been detected. They also stated that the person living with type 2 diabetes should sleep ideally between 6 to 8 hours. Otherwise, if you sleep to less than that or more than that, then it is likely to impact the A1C in negatively. If you're a night owl, then you're likely to be more susceptible to inactivity, which leads to also poor blood glucose level as well. And catch-up sleep alone is not enough. So the same article from ADA and ESD joint statement actually stated that if you have a good adequate sleep duration, that there is a very good chance that your glucose, A1C, blood pressure, lipid are all going to go down. However, if you have a really good sleep quality, then they actually make a very strong recommendations that it can reduce your glucose, blood pressure, A1C, lipid, and so on, just by fixing the sleep. Isn't that really fascinating? Something that a lot of us take it for granted. And just by improving the sleep, we can actually improve our patients' blood glucose and some of the potential outcomes. So what are some of the other impacts of the insomnia on cardiovascular disease itself? So we know that if you don't sleep well, then there's a doubling risk of developing hypertension. So in other words, there are about 224% increased risk of developing type 2 diabetes just because you don't sleep. There is also increased risk of cardiovascular death of 35%, increased risk of heart attack by 68%, increased risk of stroke close to 90%, heart failure risk goes over 50%, and cardiovascular disease risk goes up by 45% just because we don't sleep. It's really, really fascinating. And I really do believe that sleep should be considered as a foundation of life, because just because you don't sleep, it impacts not just your physical health, but mental health and quality of life, literally every single aspect of your life. So this is straight from the Diabetes Canada guideline on mental health. Really, really beautifully written chapter. And there are a couple of tables that I thought was really worthwhile for me to show. So there are a number of antipsychotic medications that a lot of physicians prescribe to aid our patients to sleep better. So these are the medications, so olanzapine, quetiapine, and clozapine, and also mirtazapine sits right there. And as you can see, unfortunately, that those are the medications that are most likely to cause weight gain. Really, really, really interesting. And we may have to rethink about prescribing these antipsychotic medications to aid our patients to sleep. What about the newer agents? So there is a aripiprazole and brexpiprazole, which are the newer antipsychotic medications that have a lot less side effect. But there are also still some potentials with the weight gain, especially with the brexpiprazole. So we have to watch out for our patients. And especially if the person has obesity or type 2 diabetes, then we may have to be very careful and look into these medications and see if we can change some of these medications. If you're not comfortable changing these medications to a different class of drugs, then maybe just consulting with the referring physicians or the family doctors may be not a bad idea. So another table from the same chapter actually shows that these 3 medications and maybe 4 medications, including mirtazapine, that we prescribe a lot to aid our patients to sleep, they are the ones that have a highest potential to cause increased weight gain, worsening of the glucose, worsening of the cholesterol and triglyceride. Once again, when we are dealing with a patient living with type 2 diabetes and obesity, we may have to rethink about prescribing these medications if possible, unless if it's absolutely indicated. So for the key learning point for the last 10 minutes is really to highlight the fact that insomnia is associated with an increased cardiovascular risk, including MI, heart failure, cardiovascular death, and stroke, and so on. Engaging the patients with the worsening insomnia symptoms in discussion for the possible cause and adherence to the treatment plan is very, very important. Some patients will respond really well just by reducing the stressors and changing of the environment, and regular follow-up may be recommended for someone with insomnia. So I hope this has been useful.